The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders.
Well, hello, Matthew. How are you doing?
I'm doing very well, Stuart. It's the end of the year. This is our recap extravaganza.
Excellent.
It's been a crazy year. It's been a challenging year, but I think overall we've held it together as a show. We now have like 28 people working with us, and some of the people have left and made their own shows, some of whom will be on the call with us tonight. So things have been great.
That's good to hear, Matt.
I did want to take this time to check in with the great Dr. Paul Nelson Williams, who is one of my very best friends. And Paul, maybe you'll remind people, what do we normally do on this show and what are we doing tonight? And if you had any inspiring words for all of us.
I mean, I can't promise inspiration. I can tell you that we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge, usually. This episode is a little bit different. This is where we sit back and reflect on all the expert interviews that we've been through and kind of highlight our particular pearls that we've enjoyed, that we've incorporated into practice, or that have been especially meaningful to us. So it's a chance to reflect back on the past year, which, as we've alluded to, has been a weird one. If I can get personal for just a minute, and I'm not going to say anything that hasn't been said before. I mean, these are sentiments that have been said sort of the entire year long, but it's just been a tough year. It's been a challenging year. It's been, in a lot of ways, a very lonely year. I think we've been isolated in ways that we have not been isolated before, and atomized in ways that we've not been able before. And so one of the things that I'm grateful for as I reflect back on the past year is to have my community of people that I work with for this show, and a chance to talk to my colleagues in a way that actually keeps me engaged and interested, and reminds me that there are people out there that care or are excited about this, because it's easy to get discouraged. It's easy to lose interest. I think it's been, it's hard to maintain intensity after a period of time. You just get tired. And then but to be with people who are like-minded and are sort of fighting the fight with you and are trying to do the same things that you are and hold the same values important, and have this community has been really meaningful to me for the past year. So I want to take this opportunity to thank not just the people that I work with directly, but our audience and the people who have engaged with us on social media and have interacted and have given us such nice feedback and made this feel like a thing and an important thing. And so it's been really helpful to me during what has been a challenging time. So I just wanted to say that up front if I could.
It's very poignant, Paul.
Stuart, did you want to add anything?
No.
Okay. All right. Well, we have with us now host of his own show, The Curbsiders, which is a pediatric sibling show to us, is the great Dr. Chris, the Chiu Man Chiu. Chris, how you doing?
I'm doing fine. I'm excited to bring everyone this end of the year recap. It's the fourth time we've done this. 2017 was the first time I produced the recap show, and we just have a fantastic show. It's an extravaganza, as we always say. It includes everything.
As we always try to convince you.
It includes everything from, the elephant in the room, COVID, to our physical exam skills, triple distilled, which is a new series we've been doing. Obviously, we're not going to do a recap show without some great Joel Topf kidney pearls. But we get to hear from some call-in pearls from our team members. And it's just been a wonderful year. And I was so happy to bring this to everyone.
Yeah, Chris, and you're talking about how long you've been with the show now, going on 3.5 years, and the show has now existed longer with this team of correspondents, many of whom have been with us for 3.5 years now. And I can say it's been considerably fun the entire time, but I don't know that it would have been able to be sustained. You all joined just at the time when we were ready to quit without extra help, and I think it's gotten a lot more fun and interesting having all these people help us out and expand, help us go onto social media, meet a lot of new friends from all over the world, all over the country, and I'm just super grateful to somehow be in the center of all this with Paul and Stuart and the rest of the team. It's been crazy.
Yeah, it's been really fun.
And I have to say,
I mirror
it's
those
changed my life.
statements as well. But- Hey, Paul, you know what I look forward to saying in 2 weeks?
No, tell me.
Hindsight is 2020.
Oh God, I hate it so much. I hate it so much.
I think Chris was just about to go into like, some heartfelt moment, and Stuart's just like, nope, I'm just gonna power right through it with my bad pun.
This is the moment. I found my time.
I missed my shot for the rim shot.
No. Too late.
All right,
Oh, wow.
I think we should get on to let's get on to some picks. Well, it is finally that time of year, and of course, to start off, we got to go. It's Christmas time. I said Christmas, Paul. I meant holidays, but please just give me a break. Okay, I didn't mean anything.
You're immediately canceled 5 seconds in the episode. That's a problem.
Festivus, guys.
Festivus, Paul.
Forget about
Happy Festivus. What's your pick? What's your gift? If you had to pick something from the Curbsiders gift guide that the great Beth Garbatelli put together, what would you pick?
It's nice of you to ask Matt, and I'm sorry to become predictable. I feel bad about it. I agonized. It's a really nice gift guide. There's a lot of really thoughtful gifts, and then I saw Cats on there, Cats the movie, and I had to stop. I can't remember if I told you guys this or not. Like I rewatched it not too long ago, and I remembered it beat for beat. Like I saw it in the movie theaters almost a year ago, and I remembered every single scene. I remembered everything that horrified me the first time through. It has wedged itself into my psyche in a way that no movie other has. So I feel like it. I say unironically, I'm starting to think it's one of the most important pieces of art I've ever seen. So if you've not seen Cats, I'm going to high recommend. It's somehow it managed to use alchemy and just turn pure awful into something that is just absolutely unforgettable. It still brings me joy because it's just the stupidest thing I've ever seen in my life. So it's just I have to recommend it. So if you've not seen Cats, buy it for a friend, watch it together. It is a movie that I think in different times would have developed a big enough cult following that people would be going in groups to watch it in the movie theaters together and yelling at the screen and stuff. Like I think it's that level of awful great. So I'm going to stick with it. I'm going to recommend it until I die.
Second only to dogs.
Stuart, what is your pick from the gift guide?
So mine's not directly from the gift guide. I'll have to admit that.
This seems completely out of character for you. Are you okay? We should probably check.
Yeah, it's fine. No, so the Expanse book series actually is what is my recommended gift. I think it exceeds the series. Didn't season 5 just come out, Chris?
Yep. Just a couple days ago.
This is the show. I believe in the past, I remember this show because I think you told everyone that you bought it on Amazon. You liked it enough, you bought it. And then the next day, they streamed it for free.
I know. Jeez, man.
Then you threw shade at them on Twitter, and then they gave you a refund.
Yeah, that's true. That's exactly what happened.
Okay, but you're saying the books are worth it.
Yeah. I will say my recommended gift is definitely not the PS5, though.
Do you have it?
No. It's funny you ask. Sony really dropped the ball on this one.
This feels like you're trying to neg Sony into also gifting you a PS5. I don't think it's going to work, actually.
No, it's not going to.
Okay, I mentioned this for Stuart and Paul. They already heard this pick of the week, but I think it's going to be on the cutting room floor from that episode. I recommend. I recently purchased a headlamp that
Flashlight?
It has a strap that you can strap this LED headlamp to your head, and you can run in the dark, which is something that I do most days to keep from going crazy. And I would highly recommend it. It's super bright. It charges up really quickly, lasts really long. It's great.
The question is, does it stay on your head when you use it with a jump rope?
Yes. And it's only like $12. It's a great purchase. If you need a gift for like, I don't know, some cousin you don't really like that much, get him a headlamp. It's $12.
Perfect stocking stuffer. That's a great pick.
Nice. So my pick is the AeroPress. I mean, I'm part of the hashtag Big Grind on Twitter, and I just love my AeroPress. I use it all the time, and it's on the gift guide, so it's definitely worth the pick. And I think it fits in most stockings. So.
I got to check this thing out. Does it make a superior cup of coffee, or does it make it faster? Why is it better than just whatever I'm doing?
Oh, what are you doing?
I'm just making drip coffee.
Well, anything's better than that.
I mean, I think it definitely tastes a little better than drip coffee and is probably just as fast.
Okay. All right. So picks of the year. these differ slightly. These don't have to be something from the gift guide, I guess. So, Paul, what's your pick of the year?
Yeah, I struggled with this, and I ended up picking the video game Death Stranding, which I had recommended on a prior episode. It is a deeply weird game by Hideo Kojima, and it's epic in scope. A lot of it is spent just sort of wandering around the countryside by yourself. But the whole game, the whole point of it, it's pointless to even try to describe the plot, but the whole game has these themes of trying to connect cities together, and basically the whole world depends on this delivery person whom you play. And everyone is completely separated from everyone else, and you only talk to each other through videos. And it's just about interpersonal connections in times of loneliness. It's about isolation. It's also about how technology unites us all. It's about how the impact of death on us, and how even death doesn't really disconnect us from other people. It has a lot of these huge themes that seemed weirdly prescient now that we've lived through all that we've lived through. It's a game I thought about a lot when I was over. And it's still, I think, has a lot of thematic relevance to sort of what we went through this year. So it's a game that I found deeply affecting and weird and enjoyable, and wasted a lot of time when I was bored inside. So I would highly recommend Death Stranding.
Stuart, you have something to say?
Good.
I mean, yeah, sure. I haven't played the game, so I couldn't say whether it's good or
I
bad.
am so excited to hear your opinion about it then.
Yeah, you're very welcome.
I think,
but it's Kojima.
I think Rick and Morty did an advertisement for it, and they were strapping like dead babies to their chest and doing stuff.
So speaking
That
of
sounds
Rick and Morty,
super dark.
yeah, I actually watched Rick and Morty for the first time this year. Maybe that'd be my pick of the year, is Rick and Morty. Oh my gosh, the Pickle Rick episode is pretty classic.
Oh,
Okay, pick of the year. My pick of the year, it's a little bit more serious. I would say maybe Paul's definitely more serious than Rick and Morty. My pick of the year is the Tim Ferriss podcast, which I think I've recommended on the show many times.
23 times at least.
I like this show because consistently they just have very interesting guests. They give great book recommendations and talk about interesting things. And more recently, I would say in the past 1 to 2 years, there's been just like a lot of talk about mental health by most of the guests who are these high-level people. Certainly something that has been very much on my mind this year, both personally, professionally, just all around. And I think it's great to hear so many like just candid conversations about people struggling with their mental health and how they're taking care of themselves. So I would highly recommend that show for many reasons. Check it out.
See, my pick of the year. So, with the pandemic, everyone started doing a lot of like bread baking.
Yeah, I don't get
And
that, Chris. Tell us about it.
I am
Bread baking?
I'm horrible at it. My pick is, so Adam Ragusa is a YouTuber. He does a lot of sometimes he does like some history and some science of foods and stuff like that. But he has this, he calls it the lazy baguette. And literally it's like, he puts a little bit of water, a little bit of flour, a little bit of yeast and salt. And then he says, shove it in the fridge, take it out 4 days later, wet, pull it out, throw it on a pan, mist the oven, and then bake it. And it's like one of the best little flat baguettes I've ever had. And it takes no time whatsoever. And it's ugly. It's really ugly bread. But so that's his lazy baguette.
I love that description. It's ugly bread.
My facial expressions are not for your lovely baguette. It's my knee. It's killing me.
Oh, sorry, bud.
We're not used to. I have to keep reminding myself that we're putting this out as a video as well as audio.
Perfect.
Because now Stuart, everyone's just gonna everyone just soak it in. Stuart Brigham. Earlier he was doing like army rolls and army crawls across his bed. You
don't understand. My knee is killing me.
All right, so Chris, why don't you bring us into the meat of the episode here?
All right, so we had a lot of great picks, and we sort of brought them in from all the team members here on the Curbsiders, and they've grown significantly the amount of team members we have, and we have some really great picks. But the elephant in the room is like you can't do pearls of 2020 and top things of 2020 without at least talking a little bit about COVID.
Do we
right?
have to?
I think it's finally time someone talked about COVID. I'm glad that we're going to address the elephant in the room. Excellent.
Yeah, COVID has changed the way that we work in some ways, maybe for the better. And I think that's what this clip's going to be about. The great Dr. Shreya Trivedi of the Core IM podcast, who's been on our podcast many times, who does the Women in Medicine podcasts. And I thought that was a great episode, just talking about how specifically there was a different burden for women during this COVID pandemic.
All right. You guys want to listen?
Yeah.
This is Dr. Shreya Trivedi, and my favorite pearl this year was from the COVID Women in Medicine episode. No surprise there. But it was when Dr. Kelly Graham spoke about the invisible cognitive load that women mentally kind of juggle around all the time, like microtasks, for example. Just a few minutes ago, it was me remembering that we hadn't sent pictures to our relatives of our 2-month-old, and we need to make sure that they don't feel left out. Small things like that, and that how that adds up over time. And she recommended writing down that mental load and kind of naming that workload that you carry around. And then she said something effective like, run your marriage like you do a business. And that was a bit surprising to hear at first, but actually, after I thought of it, was a bit practice changing for me. I actually started an Asana account with my husband, and Asana is like a project management app like Trello, but we write out things and assign it to either one of us, and it sends him email reminders so I don't have to. And yes, I'm still the one kind of carrying around the load of, okay, what needs to be written down and done, but at least it's something, and was kind of game changing for me in my day-to-day life. And I know we're all trying to make our work-life integration between medicine and all the other things we're juggling a little easier. So I really appreciated that. And with that, happy holidays and sending you all so much warm energy. Take care.
I really love that point, and I think it is important for everybody to have that conversation with your partner, or ask them to listen to the episode. And if you're like me, try to pick up some of the slack from a partner who's doing most of the work in the household, which I greatly appreciate.
I would recommend not writing memos to your significant other like you would do at work, though. Probably. Did you get that memo?
Yeah. All right. Well, thank you, Shreya, for that. Let's bring it to number 191. Produced by the great Dr. Christopher Chiu and many others. Was it Jasneet Devgun? Chris was she a resident physician who helped with this one?
Well, one of our former residents. She's now a cardiology fellow over at Henry Ford.
Yeah.
Excellent.
But the lipid updates with Dr. Aaron Mikos was really one of my favorite episodes I've ever produced for the Curbsiders, and we just had lots of great pearls from there. Matt, I think you and Stuart both had some very similar pearls coming out of that, right?
Yes, because this was we had done a bunch of lipid episodes, and I was always a little bit interested in the Lp(a), the ApoB, but I just didn't know how to use them. And she told us that for everybody, she gets at least a one-time Lp(a) to see the value, because it kind of predicts risk, and you just need to check it once. You don't need to trend it over time. The ApoB she uses when someone's near their LDL goal, but she's still worried about their risk, and she just wants to get an idea of their risk. She'll check an ApoB at that time to see if she needs to step up how aggressive she's going to be about things. And that's about to the extent that I understand it. But I did find it was potentially practice changing, because sending an Lp(a) on patients wasn't something that I've been doing before.
Yeah, and so my point was that an ApoB 100 isn't really helpful, but until they're on maximally tolerated statin, because it should kind of mirror the LDL. But for those patients who have a very strong family history of ASCVD, those are the patients that I typically would target with Lp(a). I don't really know how expensive that test is. I think it was like $50 to $100 for an Lp(a). But in my own practice, I've been able to diagnose at least 3 hyperapolipoproteinemias with that lab test. Say that 10 times fast.
I was going to ask you, I can barely spell that word. You guys going to take the show notes for that one.
Hyperapolipoproteinemia.
Impressive.
I put that pearl there just so I could say that word.
Yeah. The other thing to point out to the audience, and this was on actually the Cardio Nerds is a great new cardiology podcast that's out there. It's been recommended on the show. Those guys are super nice people. They did a whole episode on the CAC scoring, and one of the things about CAC scoring is it's actually not that expensive if someone has to pay out of pocket. I mean, it's hundreds of dollars, not thousands of dollars. And of course, it depends on the patient you're talking about. Hundreds of dollars might be a tremendous amount to some people. But depending on where you're practicing, even if they have to pay out of pocket, that may be a test. We're talking about the LP little a, ApoB, to try to get a better sense of individualized risk. The CAC score might be something you use.
I actually have the cost here from our cardiology hospital called CACLAC. It's $150 for a CAC score.
Yeah.
Well, I got to tell you, at DCash State University, it only costs $99 out of pocket.
Oh, geez.
And it has been
and that's for the imaging plus the reading, or just the imaging?
That's correct.
Okay, that's great.
It's $5 fee, $99.
Yeah. Okay. All right. So next up, one of our biggest episodes of the year, if not the biggest episode of the year. Actually, we'll get to the biggest episode of the year later. But hypothyroidism definitely was like top three. And great guest, Dr. Susan Mandel. And what I really took home, that still sticks in my mind because it's so useful counseling patients. If you have the patient who has hypothyroidism, they're feeling unwell, fatigued, what have you, you gotta counsel them that even after we normalize your TSH, it might take 2 or 3 months until you totally feel back to normal.
Right.
And Dr. Mandel said at that point, she may add T3 a couple times a day if they're still not feeling well and it's been 2 or 3 months with a normalized TSH. So yeah. I haven't done that. I don't know about you guys.
Nope.
So no, I haven't. But I was going to say that my pearl's like the opposite, right? Because the type 1, type 2 deiodinase enzyme levels actually change in severe hypothyroidism. And so there's less negative feedback. And you actually preferentially make more of the active metabolite. So for those patients that are severely hypothyroid who are being put on levothyroxine, those patients, it's actually helpful to consider beta blockers in these patients to ameliorate their symptoms instead of having them just stop the levothyroxine. That's it.
I
don't know how to follow that one up.
So biotin, Paul, what are you telling patients about biotin? Because did you know about this ahead of time?
No, I think this came up twice, and because I have the attention span of a goldfish, it blew my mind both times. So I think this was also mentioned in our hyperthyroidism episode as well. But this idea of holding biotin supplementation before doing your thyroid function tests, because if you're taking a higher dose, which most of the supplements for your shiny hair and nails are fairly high doses, it can actually result in thyroid function tests that have a pattern similar to Graves' disease. So you have this suppressed TSH and a high T3 or T4. So the counseling is before you even check a TSH, just check in with your patient, see if they're taking those supplements. And if they are, just ask them to hold them at least 48 hours before actually getting your TSH or your thyroid function test checked. So I thought that was super high yield because it's something that I don't think I'd ever considered before hearing that.
Yeah, because the dietary requirements, I don't remember exact numbers. Let's say it's like 30, whatever the units are for biotin, and there's like 10 grams in like, it's right. Something crazy like that.
Just your urine is like radioactive. It's just pure B vitamins.
Yeah. It's like, you're supposed to be getting 30. You're getting 10, you're getting 10,000. So it's crazy. Okay, so that was hypothyroidism, a really great episode. Goes way deep on that. I really think the hyperthyroid episode also was great. A favorite part of that for me, Paul, was just talking about the thyroid exam and the thyroid eye findings. We spent like 15 minutes on that, and that was just fantastic. Dr. Eve Bloomgarden did a great job there on that one.
And I think both of them, and correct me if I'm wrong, Matt, but I think both of them actually advocated for approaching the patient from the front, which in addition to sort of being trauma-informed is also completely different than you've learned in medical school.
Yeah,
so,
with the thumbs, which I've been doing, and it's been great.
And much easier than trying to not choke a patient out from behind, and that's been practice changing for me as well.
All right. Chris, what's next?
Oh, we got number 219, post-op care and complications with Dr. Avi O'Glasser, who is our chief of peri-op medicine, right?
That is absolutely correct. She is the chief of perioperative medicine. One of the great pearls from this was we just talked about how atelectasis is not a cause of fever, and then referenced a tutorial that goes through this in great detail, in hilarious detail, I would say. Because that still is proposed to me on rounds when the post-op patient has fever and I ask, what do we think caused this? That's always like, what are the first things people say? But it turns out atelectasis, not a cause of fever. And
well, they have that whole, like, I get students like winds, water,
right.
Walking. Does anyone know some of the other ones? I don't remember.
Wind, wounds, water, walking.
That's right.
Yeah. So I think that the other really good pearl there was just don't underestimate what urinary retention can do to somebody. Blood pressure, delirium, that is something you should not miss.
At AKI, I feel like that's been a recurrent theme through many of our episodes in terms of fixing things. If you just stick a Foley in there, you might actually make a lot of stuff better.
Brilliant transition, Paul, because
Right. Agreed.
not surprisingly,
As always, we have Joel Toff episodes in our recap because they were the most favorite ones of the year. Surprising.
Yeah. As a tease for the audience, what I'm told is his 16th appearance will be our first brand new interview show for 2021. And we'll be talking about nephrotic syndrome. But on this year, we had him on multiple shows, kidney transplant, AKI. Chris, what were we going to talk about first here?
Oh, well, we have the kidney boy and acute kidney injury. I think that's sort of like the big one that he did with us. But he also did, he did a whole bunch of our Neph Madness episodes. I think the one with the hyperkalemia diet K-binders was one of my favorite ones. But then the dialysis for the internist was like a really big one that Hannah had produced for us.
Just want to give a disclaimer. If you hear a kid screaming in the background, that's my daughter who's autistic. Just if you hear that.
I don't think we can hear it. So
okay,
I think the audience, everyone's used to the family members interrupting Zoom, Paul's cat's walking in the background. It's all good. But thank you, Stuart. So
you're welcome.
From the AKI episode, I think one of the biggest take homes just to keep in mind is that most of the time, and he gave us a range like 70 to 90% of the time, what's going to be wrong with the patient can be fixed by a bag of LR or a Foley. So Paul, I don't know what you were thinking about before that, but I think just having those stats in mind is super helpful. Yeah, no, exactly right. Like I think in general, and still the kidneys terrify me, though Dr. Toff has gone a long way to make them less terrifying. But the fact that your approach is sort of those two things, and then if it's ATN, which doesn't really fit in there, then the important thing is just to not hurt the patient is the other point that he made. So sort of once you have some general sense of what's going on, either hydrate them, fix the obstruction, or do nothing and try not to hurt the patient, are really the three main approaches. And if you can manage that, the kidneys will probably be okay. So I found this episode, unlike some of his, very reassuring. Right. And we asked him when we should suspect things like AIN, and he said that if you've done all these things, their volume status is okay, there's no obvious cause for the AKI, you can start to think about AIN and run the med list and things like that. But urine eosinophils not helpful. So unless you're taking a board exam, just don't do them.
Yeah.
And speaking of other causes of AKI, Justin Burke, my co-host over on the Curbsiders.
Welcome back to the Curbsiders.
Hey! Wanted to leave a little pearl from that episode as well, if you guys want to hear it.
Yeah.
One of my favorite pearls came from the kidney boy, Joel Toff, talking about acute kidney injury. I love learning more and more about how acute kidney injury from contrast does not exist. Contrast-induced nephropathy. He talked about there's no signal in the literature that contrast causes AKI. Still unconvinced, but who knows? I think if nephrology keeps doing more and more studies, eventually they'll just they'll study their way out of most of their major pathologies.
Well, Paul, do you think it does not exist at all? I don't know. I feel like I'm kind of agnostic about it now at this point. Like you don't want to take the risk of not believing it entirely. So instead you kind of hedge your bet. So if someone's tenuous, I still get nervous about it. But I think the bigger point that Joel made is if you need the study, like don't let that be the consideration that dissuades you from doing it. If someone needs contrast, then give the patient contrast. And I think is a tenet that is worth following. Yeah. And then back to the whole either LR or a Foley. Please, people, don't wait for the ultrasound to find out that the person has an obstruction or that they're retaining urine. Just bladder scan them or try the Foley and just save it for day 2 or 3 if they're not getting better before you get the ultrasound. Right. As an attending, you're in the morning rounds and you're like, where's my patient? You're trying to see the patient and they're down getting a renal ultrasound. The creatinine's already normalized because they got a bag of LR and you're just like, what the hell? They've been throwing it for the past 4 days, but you're still doing the retroperitoneal ultrasound. Exactly. Just to make sure. Yeah. Yeah. I appreciate it. I appreciate it, everybody. But you can hold off on that test. Do it at the bedside. You can fix them at the bedside often. Chris, what's next?
So, one of the live episodes you guys did, because you've guys really started off strong with doing a bunch of live episodes, then everything else happened.
so
but you guys did
sad.
a great
And then they
episode
died
on
off.
Refugee.
Sorry.
But the Refugee Health episode you guys did with Tanuja Devaraj, you guys did a great live episode, and Emi Okamoto really thought this was one of her favorite episodes, and she's got a couple words to say about that.
Hi, this is Emi Okamoto, and I'm thinking about how sometimes it's so difficult to approach sensitive topics and not feel awkward. So I really appreciated in episode 196, the live Refugee Health with Tanuja Devaraj, where she gives the 2-question screen for trauma for refugees. Number 1, have you ever experienced trauma or violence in your former country? And number 2, if so, would you like to talk about it? So quick, to the point, and something that we can be using.
Paul, you produced this one. Anything else favorite for you from that episode?
I mean, I think I was really proud of this episode. I really enjoyed this one, but I think the overall approach is sort of one of being sort of culturally competent and understanding certain symptomatology doesn't represent the things that we may sort of historically think that it manages, which I know is sort of a vague statement. But for instance, chronic pain, at least in the population that we talked about sort of as the example in that episode, is not uncommon and does not necessarily have any kind of organic cause that we're going to chase down with the $1 million imaging and the bazillion dollar workup, and sort of exploring the trauma associated possibly with the refugee experience is probably more helpful and more meaningful than sort of trying to chase down an organic cause a lot of the time. Though obviously that's a case-by-case basis. But I thought her overall approach and sort of being mindful of the culture behind the patient you're taking care of in terms of the approach, because that will impact adherence and understanding and sort of your ongoing relationship. So I just appreciated her whole gestalt to this type of care.
And along the lines of understanding the culture, one of the pearls was just talking about how certain cultures have different understandings of what a chronic disease is, or they might not have understanding of a chronic disease, and they're more used to the model, I feel sick or I feel something, that's when I take a medicine. And so you really need to make sure there's understanding that if you're trying to treat somebody with hypertension or diabetes medications, that you need to stress that they need to be taken every day in order to really do what they're supposed to do. And that was something that I think probably is overlooked. Like, you prescribe it, you feel good about yourself. You're like, I've given them the right med, but if they don't have the understanding, it's not going to work.
I thought it was interesting, the connection that with Nepal, only because of our own history with the podcast. For those who don't know,
Explain.
Early on in the podcast, we were looking at our downloads, and there was one day we had like 4,000 downloads from Nepal, and when we were only getting like, I don't know, 50 or 60 downloads a day.
Yes.
And so yeah, thanks.
So we're
Nepal.
always grateful to Nepal.
That's right.
That's the jump start.
Yeah. So do you want to talk about triple distilled? This is my favorite
Yeah,
series, mostly because
Stuart,
it's a little self-aggrandizing, really fun to record. And I think we have a pick from Isabel about the diabetes one. Did you want to play that one?
we do. I will.
Hi, everyone. I'm Isabel Valdez, the physician assistant correspondent. And my favorite pearl was from the Diabetes Triple Distilled episode number 243, where we learned that SGLT2 inhibitors increase the risk of genital fungal infections, but they don't increase the risk of urinary tract infections. Keep that one in your back pockets.
I'm going to keep that one in my front pocket.
Remember also about SGLT2 inhibitors that the black box warning for this concern over amputations, toe amputations, was removed. So I think you still have to be vigilant there, as you do with all your patients with diabetes, but that was great. And we also talked about, I don't know, Paul, have you seen someone with Fournier's gangrene being on an SGLT2, or what's the other big scary one everyone's worried about? Euglycemic DKA. I feel like that
Those are
one.
the three biggies. Yeah.
Yeah.
And I've seen none of that, happily.
I've seen the euglycemic DKA.
I have
seen
too.
that.
Yeah, I have too.
Yeah. So I think the euglycemic DKA, Stuart, you want to explain to people who's at risk for getting that with a SGLT2?
Yeah. So the patients that are most at risk for SGLT2 inhibitors are those patients that have glucotoxicity before you start them on an SGLT2 inhibitor, because that suggests that they're kind of on the teetering point where they're relying on their glucose for at least part of their substrate. And if you completely get rid of that glucose, then they're going to rely on ketogenesis.
Yeah.
And that's a very bad place to start your patient on it. So typically, I don't start patients on an SGLT2 inhibitor until I know they've either been stable for a long period of time, or I can get their A1C. There's really no guidance for this, but the way that I approach it is an A1C of at least 10 or less, but ideally 9 or less before I put them on an SGLT2 inhibitor, because you also get massive diuresis the higher the glucose is over the threshold, the glomerular filtration threshold of about 180 milligrams per deciliter. So, and that also kind of is a segue to the blood pressure lowering. So for all patients, and this is interesting actually, it lowers their blood pressure almost as much as thiazide-like diuretics, but that can be even more pronounced with your diabetics that are less well controlled.
So Stuart's evidently been keeping track of the number of compliments I've paid him, and it was 5 at last count. I actually want to say this will be number 6. In that actually your pearl from this episode has been practice changing for me, and I'm actually a lot more mindful of sort of background A1C and sort of how hyperglycemic a patient is before I pull the trigger on the SGLT2. So actually your teaching point with that has helped me a lot in my own with my own patients. So compliment number 6 for the year. We'll finish out strong.
And I will say that this is, quote, expert opinion. This is not, there's no guideline for this. This is just based off of using this medication. I was one of the earlier adopters in our clinical setting and noticing some of this earlier on.
We had some pearls from the physical exam episode. We had a pilot of this physical exam series that the great Dr. Justin Burke is going to be bringing to us with the Society for Bedside Medicine. And the first one we did was an approach to shortness of breath. For me, from that episode, I thought what Dr. Garibaldi said about doing a hypothesis-driven physical exam, I hadn't heard that phrase before, and it immediately clicked with what he meant it was. He said, before I even go to put my stethoscope on the patient, I've already done all this inspection and palpation, and I really know exactly, I know what I'm looking for, and I'm trying to answer a question. He's not just going through the physical exam, going through the motions. He's doing it. He has some idea of the likelihood ratio of what he's doing, and which test would be helpful or not to push him in one direction to reach a post-test probability that might change his thoughts. I see you nodding, Paul.
Yeah, I can't remember if I said this on the episode or not, because Brian said it so much more eloquently than I have said it before, but the best advice I ever got about the physical exam is to cheat. So meaning if you see someone who's very old, who's syncopized, expect to hear the murmur of aortic stenosis. If you know someone has a history of decompensated heart failure, expect to feel the displaced PMI or expect to hear the S3. You have to be going in. You can't just let the findings wash over you. You should actually be listening specifically for the findings that actually strengthen or refute your diagnoses. And I think when you approach things like that, you're much more likely to actually hear the subtle findings that will not just declare themselves to you if you're going in undifferentiated. So I thought he explained that point much better than I ever have, even though I think I've been trying to say that to students for years. So yeah, I like that point a lot.
I think we should go on to...
You've been trying to tell students to cheat?
Yeah, 100%.
Okay.
Let's go on. Let's go to number 230, Kittleson Rules Acute Heart Failure, or Kittleson Rules Heart Failure, produced by newcomer, hotshot Deborah, soon to be Dr. Deborah Gorth, 8th year medical student, as she proclaims herself. She's really done great stuff for us this year. And this was also, I would say, one of the top episodes of the year, fan favorites. It seemed to be, certainly by download numbers and just by the chatter about it on Twitter. So
the Twitter engagement was bananas. There were so many great conversations, and Dr. Kittleson continued to teach on Twitter about the points that she made. That was a lot of fun to see how this expanded.
Right. So I don't know if we have audio of this, Chris, but Deb left us some pics. Was any of this practice changing for you, Chris, or were you already doing some of these things? I know you read and listen to more medicine than anybody else I know. So I wouldn't be surprised if you knew this stuff.
Well, there definitely were a couple things. So one of the studies that she referenced was the dose study, which is what she used when she was talking about the diuretic drips versus intermittent dosing. And that's definitely one I've been talking to my residents and students for years about. And I think it's one people need to take a look at. But, using that study, she started talking about like using 2.5 times the home dose. And I know there's some discussion about that. I think there is a lot of, people practice a little differently in terms of starting off their initial diuretic dose, but I think no one denies that you need to increase their somehow you got to increase the concentration of the diuretic when you admit a patient with heart failure. So what's going on, Stuart? You're a little upset.
It kills me when someone orders Lasix twice daily. It just kills me because your patient can't sleep. They end up getting their Lasix like at, I don't know, 9 a.m. and 9 p.m. And then, you're shocked when the patient can't sleep at night. One of the things that I always talk to my residents about, time it like 8 a.m. and 2 p.m. That way it's out of their system before they go to bed and they can actually sleep. And the same thing with even IV doses. I mean, I see that one of the pearls was, essentially let your patients sleep with the diuretic. And I couldn't agree more. But that's something that we really don't think about a lot on the wards, and it needs to be considered.
Yeah. If someone's on a drip, a furosemide drip, a bumetanide drip, maybe a Foley, that might be one time it's humane to have a Foley, or just turn it off at night, I think is what Dr.
Right.
Kittleson said, so they don't have to be getting up every hour, especially if they're not having a Foley. I do, Dr. Topf, way back, our first ever episode with him, one of his pearls about diuretics was, if you give the dose of diuretic and it doesn't work, you're giving it IV. If you look at the package label for all the IV medications, it's like less than 30 minutes. I think it's even less than 15 minutes that they should start to act. So if you don't start to see urine in that Foley bag within an hour, then that dose wasn't enough, and you can double the dose and give it again right there. You don't have to say, well, I gave 20, so that now I'm going to give another 20 and that'll be 40. No, you just give 40 right then.
Right. Or send your night float on the sad quest of it like 3 o'clock in the morning, calculating eyes and nose and giving the same dose of Lasix at like 2 in the morning. 100%, like try to keep them 2 liters negative. I'm like, well, 3 in the morning, time for your Lasix, I guess.
Think back of all those futile night float things we were doing before we understood diuretics so well. All right.
And I want to give a big plug for Dr. Kittleson here. So, if people are not following her on Twitter, and she is one of these people who, she's not always on Twitter and giving something every single day, but when she has one of her Kittleson rules and she puts it up, it's always just phenomenal. And I did an interview on her on a different platform, and she's just a wonderful person to talk about. She has been doing these Kittleson rules for years, and her residents and her fellows know about them. They have written books about them, and they share among their colleagues. And if you're on Twitter and you don't follow Dr. Kittleson, then you are missing out.
So you're gonna have to excuse my ignorance here, but I can't remember if we talked about this or not. For SGLT2 inhibitors, and so one of the things that's oftentimes stopped, if you have a diabetic patient, for example, who's being admitted for heart failure, don't stop the SGLT2 inhibitor. That can actually help to potentiate the diuretic effect of the loop diuretic that they're on. But you do need to watch their volume status, make sure they don't over-diurese.
Completely agree.
There's also some
like
evidence about using
right?
SGLT2 inhibitors for heart failure patients, but that's a separate issue entirely.
Speaking of Twitter phenoms and fantastic educators, another newcomer to our show, Dr. Bahuma Tatanji of Emory, where she is a like 4th year ID fellow, but she's also has like 10 degrees already, and she's got like TED Talks, and she's amazing.
Phenomenal speaker.
We talked to her about urinary tract infections, and we talked about the first line agents, nitrofurantoin, trimsulfa, fosfomycin, and one of the big things that she said was that not all UTIs in men have to be treated as complicated. You can still use the first line agents in them, and you don't have to do a 14-day course with like a quinolone in every man that has a UTI. So I beg of you, audience, please. We're sort of moving to this thing with UTIs where if they have systemic symptoms or if they have upper tract findings, like they have flank pain, then you might take it more seriously, but and treat with a bigger gun. But if they just have cystitis and it's a man and they're otherwise well, you can use one of these first-line agents. Paul, I see vigorous head nodding.
Right. Though, I mean, you should still pause, think, and what might actually be causing that. But yes, exactly. Her framework for sort of separating simple cystitis, bladder and below, and complicated above the level of the bladder, I thought was just a really easy way to think about it that also had not occurred to me before. It's one of those other things that kind of made me feel stupid for the way I behaved for the past decade.
Right. And I think we have a clip, Chris.
Yeah, we got one from Elena.
This is producer Elena Gibson, and my favorite pearl of the year was Dr. Tatanji's approach to UTI diagnosis and reminder that enteric bacteria such as E. coli or Proteus convert nitrates to nitrites, but it takes about 4 hours. So if you want to avoid a false negative, then try to get an early morning sample, or at least take it into account if you get one later in the day. Have a good year.
I had never heard that before, and it's like, it was amazing. I love that pearl.
I am 6 figures in debt. Someone should have told that to me.
Yes, what the big thing there is all these times you're like, oh, no nitrites, I'm less suspicious. It's like, well, you got this in the middle of the day when the person's on got in 3 liters of IV fluids today. And they've been peeing every 5 minutes. So that I agree. And then the other thing was that leukoesterase is a sign that there's white blood cells in the urine. When you do the microscopy portion and you're seeing pyuria, like greater than 10 white cells per high-powered field, that's considered pyuria. Leukoesterase tells you you're probably going to find pyuria. And the absence of pyuria is helpful, but the presence of pyuria does not really mean you have a UTI on your hands.
Right.
Yeah. And speaking about UTIs and getting fluids, I think Paul wants to talk about 4 buckets for episode 221, interstitial lung disease.
Smashing transitions.
I know.
Smashing transition.
Isn't it? I was thinking about that one.
All right. Okay. Good.
Go ahead, Paul.
This feels almost like a professional show. I am staggered. This is episode 221 with the great Dr. Nareski, who I clarified a topic that I have found and continue to find somewhat baffling, but she made it much less baffling. I think in terms of all the classification schema and all the diagnoses associated with interstitial lung disease, I just didn't have a great way to approach how to think about it. And Dr. Nareski talks about these 4 buckets that can potentially be associated with interstitial lung disease, whether it's connective tissue-related disease, sarcoidosis, hypersensitivity, or the idiopathic. And then those are the 4 big buckets that she thinks about. And then the other thing that she talked about that I really enjoyed is in terms of how important the history is, which speaks to my heart. So she really, I think, gave some great tips about going through specific exposures. Pulmonologists, as we talked about before, have a particular hatred of down pillows and ducks. So it's worth asking about your patients too. Right, yeah, just birds in general, they hate and are excited about at the same time. But she made the point that oftentimes your PFTs have not caught up to the patient's underlying disease, and they may have symptoms before the PFTs even manifested, or even before you find necessarily physical examination findings like the classic inspiratory crackles and that kind of stuff. So be diligent. I had a hard time saying diligent for some reason, and have sort of a low index of suspicion for your patients that you're thinking about it for.
Paul, I love that you use the word baffling, because were you too baffled by NAFLD? Because that's episode 227, and you have a pearl on that one as well.
I don't understand what's happening here. I don't like it.
Stuart's paying attention and he's moving the show along, Paul. What is happening?
Wow.
I am actually dying in my chair. DMT is being released by my brain, and eventually a fox is going to lead me into the afterlife. But no, you're exactly right. So another pearl I loved.
I like how you put MAFLD in the script, though.
All right. So talking to the amazing Dr. Matherly about the metabolic associated fatty liver disease, otherwise known as non-alcoholic fatty liver disease, but there's a newer framework and a newer discussion about how to talk about it. He made a couple of great points. 2 of the pearls I particularly loved is everyone gets a little bit squirrely starting statins or continuing statins in patients with underlying liver disease, but he made the point that for most patients, unless you have, I think it's 3 times the upper limit of normal for the transaminases, you should be perfectly comfortable, especially with MAFLD, because there's a significant amount of cardiovascular mortality associated with that, because that tends to ride along with the metabolic syndrome type picture. These patients are at risk for atherosclerotic cardiovascular disease, so do not fear statins to these patients. In fact, statins away. And then the other point that he made that I also really enjoyed is that don't be fooled by normal transaminases because there are different reference ranges per different labs, but even sort of minimally elevated ALT specifically can be indicative of underlying liver pathology and should raise your antenna to think about fatty liver disease. So I think he gave a specific number of greater than 25 in females or 33 in males. So anything above that is abnormal and should prompt a little bit more consideration. So I thought 2 really practical tips that are broadly applicable to my patients.
Yeah, fantastic. Please don't stop statins. I think he even gave the 3 times. He gave range. He said like above 150 or 200. That's where he starts to think about stopping a medicine that might be hepatotoxic.
It's statin. It makes sense.
I think we actually might have skipped over one, Stuart. Do you have a fancy transition for number 13 on our list here, or number 242?
Oh, I saw all the lines and I thought, you know what? I got lost in the weeds, kind of like being in the wilderness. So we've got Wilderness Medicine with Tom DeLore, episode number 242.
So fancy.
Yes.
Why don't we go to a producer here? Chris, do you have a clip for us?
Yeah, so sorry. I got.
No, I know. Up is down, left is right. Sauerkraut's delicious. None of this makes any sense, Chris. But just grab hold. Ride the lightning, buddy. We can do this.
So you stole Maddie's.
This is social media guru Madison Mad Dog Morgan, and my favorite pearl of the year was Dr. Tom Lowry's Wilderness in Medicine episode.
And from that episode, the great Dr. Rahul Ganatra has a great pick that you gotta listen to.
This is Rahul Ganatra, the Curbsiders Critical Appraisal Consultant. One of my favorite pearls this year was from episode 242 with Dr. Tom DeLore about preventing rabies, which I'll never forget because he told a story about getting a bat bite himself while out for a run. Apparently, if you just wash the bite wound with soap and water, that reduces the incidence of rabies by a whopping 50%. And as everybody knows, I love a good effect size, and a 50% relative risk reduction is mighty nice.
He also loves fun animal facts, which is why most of our COVID cake shows or hot cake shows have fun animal facts at the top of the show. Oh, gosh.
Just the absurdly charming Rahul Ganatra, everybody.
Also, for the audience not watching the video, Stuart again is having knee pain, is crouching in the corner of his room in tears.
It hurts!
Poor guy.
Okay, I'll give a wilderness medicine very quickly. Hypothermia we talked about. And there's a cold card that we talked about where it gives you there's this spiral on it, and it gives you the various stages of severity of hypothermia. And if someone is just mildly hypothermic, that's not the biggest deal. Try to warm them up, try to get them moving. If somebody's hypothermic to the point where they have like altered consciousness and then you want to keep them on the ground because you want to keep the blood in their core. If you actually stand them up, actually that core blood, which is warm because it's at the core, will circulate to the cold extremities. It'll get cold, circulate back to the core, and they'll start to spiral. That was terrifying to me because I had never heard that before. So definitely check out that section of this. Check out the cold card. And I thought the other thing that he said is giving people calories to help them shiver because they need a lot of calories to help them shiver to warm themselves up is also important. So like that's one time you can give them like soda and candy, and that part sounds kind of fun.
I think like I couldn't get him to engage with this, but I think there's a recommendation against crawling in the sleeping bag with them, and you refuse to either refute or deny that because it gets in the way of the patient shivering. But anyway.
Hey, Paul, are you balding? Are you losing hair?
That's feels like less of a transition and more of a personal attack, Stuart.
Oh man, that's rough, dude.
No, Stuart, but I am. So can you please? What are you getting at?
That's wonderful because there were some great pearls that Paul wanted to talk about on the Skinship episode, the Scalp and Face episode number 232. Paul, you're balding.
All right. Well, that was great while it lasted, Stuart. Glad to have you back. So it's a great episode indeed. I think the thing that I took away from episode 232 that was probably most helpful was an approach to the patient with hair loss. I feel like it's something I never had a framework for. I would kind of throw a TSH at them and hope it revealed something and then wouldn't, and then I'd feel bad about myself and eventually refer them to dermatology. But in terms of actually having a differential now to think about and thinking about scarring versus non-scarring alopecia, scarring being a little bit more time sensitive, I think our guest made the point that follicles are time is follicles, so get these people to dermatologists quickly if you think there's scarring alopecia. And then in terms of the non-scarring, differentiating between alopecia areata, where it's autoimmune and you sort of lose patches of hair, versus the very common androgenic alopecia, for which we all live in fear, where you have widening of the central part and these very shiny bald spots because of increased sebum production, versus the telogen effluvium, where there's some sort of antecedent stressful event. So in the year of COVID, we're all just losing hair left and right, or maybe that's just me projecting.
That's the one the patient brings in the bag of hair.
Yeah,
Yes.
Exactly right. And so to have some way to think about these things and then different ways to actually address the problems once you have a diagnosis, I found extraordinarily helpful because I was just kind of at sea before.
Yeah. Okay. And thank you for those pearls, Paul. And as we fade into the outro, some more pearls, favorite pearls from our Twitter, what am I saying here?
Try it again, Matt. Try it again.
And as we fade into the outro, Beth Garbitelli from Twitter fame will give us her favorite pearls from this year.
That was slick.
Hi, this is Beth Garbitelli. I'm a producer and correspondent for the Curbsiders, and I also manage the Twitter account. In trying to think about my favorite episodes from this year, there was just so many good ones that it was hard for me to pick, as usual. But two that really stood out to me were fatigue for primary care and homeless healthcare. The fatigue episode felt for me to be like such a helpful overview of a topic that, when it comes up in a primary care clinic visit, can be really daunting. And I think sometimes can get really oversimplified to sort of just focusing on things like depression and anxiety causing fatigue. But I felt it gave a really helpful sort of schema for working through the differential for fatigue and really practical tips for managing lab workup and how to counsel patients when we don't have a good answer. So I thought it was a really, really helpful episode that I've thought about a lot during my third year for my clinic visits. And I also really enjoyed the homeless healthcare episode, in addition to sort of shedding a light on a really important topic and sort of emphasizing how much of an impact homelessness can have on a person's health. There were some tips that really stuck with me, like the examination of a person's feet, which may not always come to your mind when somebody's coming into an emergency department visit for, something else. But also the idea of sort of, keeping in mind what their capacity is for certain types of medication regimens and things like that may require them to go to the bathroom or have regular lab checks. It was a good mix of really practical tips for, improving your care for a person experiencing homelessness, as well as giving folks an overview of the topic of homelessness and its impacts. So in short, this has been a great year with the Curbsiders. As always, I'm very proud and feel very honored to be able to work on the show with a really amazing, outstanding team of producers. And I hope everybody is staying safe and has a really happy and healthy holiday season. And cheers to 2021.
Thanks, Garbs.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right, Paul, because we're committed to providing you with high-value, practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact Matt directly. He's waiting for it at thecurbsiders@gmail.com. A special thanks to all of our producers and team members for the Curbsiders. It's an exhaustive list, but it includes, but not limited to, our social media team, Beth Garbitelli on Twitter, Maddie Mad Dog Morgan on Instagram, Tima Karganov on our website, and Chris the Chiu Man, who's actually right here, but also on Facebook. Until next time, I've been Stuart Kent Brigham.
And thanks to Chris for putting together this. This is Chris's fourth recap episode. He's been working with us for over, I don't know, Chris, how many years now? Going on 4 years?
For three and a half
years.
Right?
Yeah. And so this has been great every year. Thank you, Chris. I also wanted to thank Stuart Brigham for composing our theme music and to Claire Morgan of Notterly for editing our audio and
Claire.
sometimes our videos like this one. And
Godspeed, buddy.
until next time, I've been Dr. Matthew Frank Watto.
Hello, this is Emmy Okamoto, and I'm sending you some warmth and sunshine from Cambodia. I want to extend a huge thank you to all the workers, particularly the frontline workers, showing incredible courage and selflessness to get out there every day through the challenges. So thank you. I hope through this past year we've all had some time and space to find some inner peace through the struggle, and I'm very much looking forward to a better 2021. Wishing you a safe and very happy holidays.
This is Dr. Cyrus Askin. Happy holidays.
Hey, this is Edison Jang.
This has been Beth Garbatelli signing out.
And this has been Deb. I don't have an actual sign off yet. Gore.
This has been Physician Assistant Correspondent Isabel Valdez.
This is Justin Lee Burke.
This has been Maddie, the Mad Dog Morgan.
For the Curbsiders, I've been Dr. Rahul Ganatra.
This has been Hannah R. Abrams.
I've been Kate Elizabeth Grant.
And this has been Leah Witt.
And this has been Dr. Shreya Trivedi.
Happy holidays. This has been Dr. Molly Hoybein.
Hi, this has been Sarah Phoebe Roberts, and I'm wishing you all happy holidays.
And this has been Chris the Chiu Man Chiu.
And as always, I remain Dr. Paul Nelson Williams. Happy holidays. Thank you and goodbye.
Goodbye, Paul.